Welcome back, everyone. This is Dr. Lin from Sunrise Urology here in Gilbert, Arizona. Thank you again for watching. We all know about the bad things with radiation and what radiation causes, such as sunburns, atomic bomb. But today, we are going to talk about the good things about radiation. Let me introduce you to Dr. Davis Romney from Ironwood Cancer and Research Centers. He is a radiation oncologist, undergrad at University of Arizona, and then additional training medical school at University of Virginia, and he also trained in radiation oncology at University of Virginia through your residency there. American Board of Radiology certified in radiation oncology.
Yes, sir.
Yep. Big wig. So today, if you guys have any questions during the live stream, please feel free to ask in the comments. If you're watching this on a replay, type your questions in there. I'm sure I will try to direct the questions to Dr. Romney, or I'll try to answer them myself. At the end of the towards the end of the live Facebook live stream, we will answer and demystify some of the things that you may not understand or may be misinformed about radiation oncology. All right, so first of all, what is radiotherapy and what is radiation oncology? And
well, thank you, Dr. Lin. First of all, thank you for having me for your Facebook Live program. I really appreciate the opportunity to dispel some of the myths about radiation and talk more specifically about how radiation works and what it's used for. So ionizing radiation is along the electromagnetic spectrum, right? I think you've got a graphic for that. It's basically visible light. Here you can see where the color spectrum is on that graphic. That's visible light. If you're at a lower wavelength or lower frequency than that, then you're in the infrared spectrum of that energy. Or if you're at a higher energy than that, you go into ultraviolet or X-rays. So most of what we talk about with radiation therapy, we're talking about X-rays. X-rays are waves of energy or photons of energy that are not visible, but that can be very powerful at high energies. And we can utilize X-rays to treat cancer. This works by causing chemical breaks in chemical bonds, specifically in the DNA. So if we can create a double strand break in the DNA, we can effectively arrest that cell's growth and create what's known as apoptosis or programmed cell death. That is the basic way of how radiation works.
So we're using a small amount of the radio frequency spectrum and taking that energy to kill cancer cells and using the apoptosis or breaking up the DNA strands. And the underlying concept from what I understand is that cancer cells have a hard time repairing themselves.
Very good. That's correct. So one of the advantages of radiation is that the cancer cells are programmed for growth. They're not really programmed for repair. So one of the techniques that we utilize is fractionating the radiation, where we give a small amount of radiation each day over a period of time. And so that our healthy cells have an opportunity to repair some of that damage in between treatments, whereas with the cancer cells, you're killing more and more cells with each treatment. And so that's one of the techniques that we utilize in order to kill more cancer and have fewer side effects. Another method is how you direct the radiation and its ability to target the cancer while avoiding radiation to the healthy organs that are close by. An example of prostate cancer is you're a urologist, and we see a lot of prostate cancer. The two major organs that are adjacent to the prostate are the bladder and the rectum. And so bladder toxicities and rectal toxicities we're very conscientious of those as we design our treatment, so that we can focus the radiation down on the prostate while minimizing the radiation exposure to the healthy tissues, in this case to the bladder and to the rectum.
So before we jump ahead to treatment of prostate cancer, let's talk about the different types of radiation that are commonly available in your armamentarium in treating different types of cancers.
Absolutely. So when we talk about radiation, the main form of radiation that we're talking about is external beam radiation. External beam radiation means you have a linear accelerator or a machine that uses electricity to generate a beam of X-rays that you can then target at a cancer from outside the body. So external radiation, now that covers multiple different types of radiation under that umbrella. And this is where you hear about 3D conformal radiation, intensity modulated radiation therapy, image guided radiation, stereotactic radiation therapy. They all kind of fall under that umbrella of external beam radiation. Each of those technologies has its advantages and disadvantages in targeting different forms of cancer. Another type of radiation we call brachytherapy is using a radioactive source implanted into a tumor. So instead of using a machine to generate a beam of X-rays from outside the body, you're actually using a radioactive isotope to implant into a tumor and then to give radiation from the inside out. All right. So for prostate cancer, we can use brachytherapy, implant seeds. If you've heard of a seed implant, I'm sure most people have heard of a prostate seed implant.
Sure.
You implant these radioactive sources throughout the prostate, and over time they give off their radiation internally to treat the cancer. So those are the two main forms of radiation that we utilize. The most common type that we use for prostate cancer is the IMRT, or external beam radiation, where IMRT basically stands for intensity modulated radiation therapy, which allows us to shape the radiation effectively into the shape of the prostate. So in that way, we're, instead of coming from one angle here and one angle there and creating a box of radiation that's square shaped around a spherical organ, and that doesn't make any sense.
Yeah, kind of like
there you, here's a great graphic for you right there, where the red area, that concentrated area in the center, is the effective amount of radiation, and then the low doses of radiation that are inert, that have no effect on the body, are represented by the blue and the green areas on that graph, so that you can come from multiple angles, and where they intersect at the center, you get your dose cloud of radiation shaped or in the shape of the prostate.
So in essence, you want to concentrate the radiation at the area where you want it to go, but then miss everything else.
Correct.
So you're not damaging.
That's correct. So that we target our area and minimize the adjacent organs. And then again, we use that fractionation or multiple treatment model to give the healthy tissue a chance to repair in between each treatment. Now, if it was perfect at doing that, you would have no side effects of the treatment. But, it's not. So there are potential side effects of radiation. First of all, some of the common misconceptions are that radiation burns, or there's heat, that you feel like this sensation from the treatment, and that's simply not true. Radiation is painless. You feel nothing. But what radiation can do over time is create inflammation. And so if you get inflammation in the bladder and inflammation in the rectum, then you can have irritation in urination, frequent urination, getting up more at night to go, urge to go right away and have to hurry up to the bathroom, or even when that urge comes, having trouble controlling and having some incontinence or some leakage.
Sure.
Those are some fairly common and temporary side effects during the radiation treatment. That can also cross over to the rectum, where you're having frequent bowel movements or an urge with a bowel movement if you're creating inflammation there as well.
But there are ways to, from what I understand, there's something new, relatively new, called the spacer that you can
That's
can apply.
Correct. So spacer is technology based off of plastic surgery, actually. So this hydrogel, which is like an injectable filler, which is used in plastic surgery, can be injected essentially between the rectum and the prostate, giving you a little bit of cushion to create that space and kind of move the rectum away from the prostate, and can help minimize even some of that from the external radiation to the rectal area.
So this is in the case of prostate cancer.
Correct. Right now, this is utilized for prostate cancer. And it's not that commonly done because the rectal toxicities with our current technology are only on the order of about 5%. They're pretty low. And this gets you down to 1%. So it depends on the motivation of the patient too, because the procedure to put that in there, as you can imagine, is a little bit invasive.
Sure.
So it's one of those new technologies that's kind of neat that that we utilize in select cases, and that can be beneficial. And if they could find a better way of getting it in there, I think we would do more of them.
That is for sure. That's always the case with any sort of medical therapy, right? We have come
That's
up with these
right.
great ideas, and the delivery is what is not
Yeah.
so well tolerated.
Yeah, the invasiveness of it is what kind of scares people away. But where that technology may be more beneficial even is in proton therapy. So protons are very fashionable these days. Very popular. We hear a lot about proton therapy. It's really not that new. It's been around for a long time, but many of these centers have come up lately. So I think it's important to address proton as a form of external beam radiation. But instead of using electricity to generate an X-ray, you're using a cyclotron to generate a stream of protons.
Sure.
Now, for all those who remember high school chemistry, right, a proton is a positively charged subatomic particle. It has charge and it has mass. And because of those properties, instead of being a wave of energy like an X-ray, this mass can actually collide with matter, with your body, slow down and stop. So if you can stop the proton inside the prostate and it deposit its energy into the prostate, then you have no exit dose and you can be even more conformal with the treatment. The issue with protons, and there are several, is that number one, it's super expensive. It costs about $100 million to build a proton facility.
Wow.
And the treatments then are very expensive, about 3 or 4 times the amount of standard radiation. So as you can imagine, insurance companies aren't too excited about paying for it. But if it was showing great promise in the treatment of prostate cancer and curing more patients and having fewer toxicities, then we'd all be running for it.
Yes.
And the bottom line is that simply hasn't, been the case. We actually see maybe a slightly higher radiobiologic effect of the protons, and so there's been an increased incidence of rectal damage for some of these patients, and so you have to be very, very careful. Whereas the space-4 might be a good technology for proton therapy centers to start using and maybe utilize more of. But at this point in time, protons are a neat idea. They're available for someone who wants to really seek it out if their insurance company will cover it. But we always have to be cautious with new technology and how we utilize things.
I try to keep up with all the different radiotherapies and at these conferences that I attend. The absolute benefit of proton has not been clearly defined.
It has not been well defined.
But it's much more costly. It costs a lot more, that's for sure.
Yeah, 3 or 4 times. I think where protons really have their benefit is in treating children in particular. And that's because if you cure a child of cancer and they're going to live a lifetime, every bit of radiation exposure, even low amounts of radiation to their body matters. Because you can develop a cancer from that radiation. And without an exit dose on the proton side, I think that's really who benefits the most from proton therapy. That's proven. But in terms of prostate cancer, I think proton therapy is overutilized for prostate cancer.
Yeah.
But they need patients to keep the doors open, right? To pay for that $100 million building, you need patients in order to do that. And so that's a patient pool that they've really tried to utilize.
And that's why a lot of patients hear about advertising for that particular type of therapy. So it's very interesting. The proton beam accelerator versus a linear accelerator that is typically used in radiation centers, such as those at Ironwood Cancer. Those linear accelerators are maybe a few million dollars,
maybe $3 or $4 million.
Still outrageously expensive.
Very, very expensive. But not $100 million to build, a full proton therapy center with a cyclotron and 4 or 5 treatment vaults and whatnot.
But that's what's hot, because there's a lot of patients are asking about it because of the advertising dollars that are being put into the
and they're
market.
spending a lot of money on advertising. They got to build that center and pay for it. So
yeah. So you briefly mentioned about fractionation, and I want to go back to that relative to prostate cancer. I diagnose prostate cancer. Some of the patients wish to have radiotherapy. I referred my patients to you, and then they are given these little doses over a long period of time. I tell them Monday through Friday for several weeks. Can you talk about fractionation and how that works?
So standard fractionation or conventional fractionation, we're looking to get to doses of around, for a low-risk prostate cancer, close to 80 gray, 78 to 80 gray of radiation. For a high-risk prostate cancer, at least 80 or 81 gray of radiation. If we divide that up into 2 gray fractions, and then that'll take almost 8 weeks.
So
8 or
every
9
time
weeks.
the patient gets a treatment, they're getting about 2 gray.
About 2 gray. Now that's standard conventional fractionation. One of the other newer things that's out there are hypo fractionated treatment regimens. We're always looking for ways to reduce costs. And one way to reduce costs is to reduce the number of treatments. It only makes sense. So there are alternative regimens that have been published that are a little bit shorter that have shown, at least right now, equivalency in
as
terms
far
of
as
cancer
cure.
control.
Okay.
But some of those have a little higher risk of toxicity, especially urinary toxicity in the short term, because you're giving more radiation per treatment. And we said from the outset, right, we're trying to minimize toxicity with this fractionation.
Yes.
More urinary symptoms that peak higher, right, that are stronger urinary symptoms, but maybe they don't last quite as long because the treatment's shorter.
Yes.
So you'll still have urgency, frequency, but you'll have more of it, but maybe instead of lasting 8 weeks, it lasts for 6 weeks. And so that's kind of the trade-off with some of these regimens. And I've utilized those in select cases. If someone is traveling for work, they can't come back and forth for 8 weeks. We'd consider doing shorter treatment regimens with higher doses as long as they know and understand, what the trade-offs are.
Yeah.
And so there's a lot of flexibility that we have in how we administer radiation in our dose fractionation schedules. And this is all published through national guidelines. This isn't Dr. Romney making up his own regimen.
You bet.
There are national guidelines where we follow all the latest studies that are published and what's acceptable. And, if you have prostate cancer and we sit down and talk, we'll go over all of those things and, discuss the pros and cons of each of those different regimens.
Yeah, you bet. I like to switch gears and go back to the misconceptions that people have about radiation therapy. You mentioned something about people thinking that they're getting burned with radiotherapy, but that is simply not true. The other thing that people are worried is that once they get the radiation, external beam radiation, is it okay to be around other people? Is it okay to hug a family member?
Great question. So with the external beam radiation, which is the most common form, again, going back to the linear accelerator, IMRT, that radiation is in the room and it's on. It's like a flashlight. It's there, it's on. When it's off, it's not. So you don't carry it around with you. So you're never radioactive when you're doing external beam radiation.
So important to know.
You're totally safe for the public. You're safe for your family. You're safe for kids and everyone else. If you did a brachytherapy or the seed implant, now you have radioactivity implanted in your body and you're emitting radiation, albeit very, very low amounts escape your body. What we tell patients is the amount to your spouse over the lifetime of the implant is about the same as taking a flight from New York to Tokyo. So when you go up really high in the atmosphere, you're getting celestial radiation, radiation from the atmosphere. So that's about how much radiation, a flight from Tokyo to New York, that the spouse would receive from her husband's prostate seed implant. So it's a very, very low amount. It's a very safe amount, but it isn't zero. And so if you have a prostate seed implant, we tell you, you don't have children sit on your lap for, the first 6 months after the implant. We give some general radiation safety precautions as well in case a loose seed comes out in the urine or in the semen.
Sure.
What to do and how to handle that.
Yeah, that's so rare though, and
very rare.
Just so that everyone understands, the radiation in the seeds, they disappear. They lose their energy over time.
That's correct.
So,
the most common seed implant that we use in the United States is an iodine 125 or I-125 seed implant. It has a half-life of about 60 days. So every 2 months it's losing half its energy. So after 3 half-lives, about 90% of the total radiation of the lifetime of that implant is gone. And so at that point it's basically inert.
Yeah, not to have to worry about.
That's correct.
Yep, sounds good. And looks like we have someone mentioning, Jill says Dr. Romney is a legend. If you all have any questions, please feel free to ask them in the comments during the live stream. Otherwise, feel free to leave them in the comments. If you're watching this on the replay, we will try to answer them for you. Let's go on with the misconceptions and myths. About
Yeah,
what about how radiation may affect the immune system?
that's a great question. A lot of people confuse chemotherapy and radiation. And they, think cancer treatment, they imagine in their mind someone who's lost all their hair and they're sick. So radiation side effects are all dependent on the area of the body that you're treating. The effects are localized. So if you're radiating in the lung, then the side effects are going to be here in the chest and in the lung. If you're radiating in the stomach, then that's where the side effects are going to be. Radiation does not cause a measurable drop in your immune system. It generally doesn't make, at least prostate cancer radiation, you don't get sick to your stomach, no nausea, no vomiting, no hair loss. So you'd only have hair loss if you were irradiating the head or the brain, right? And so that's a very common misconception that I'm going to get radiation and I'm going to get really sick.
Yeah,
You
a
know?
lot of people, some patients ask me that before I refer them to you.
Yeah.
They will ask me, "Am I going to lose my hair? Am I going to be sick?" And I
Yeah.
tell them, "No, no, no. It is truly just limited to the area where the
Yeah,
radiation
it's
is being
very
delivered."
localized. Now, we do caution all patients that radiation can cause cancer, right? So, we try to limit our radiation exposure through our lifetime, our medical x-ray exposure. So when we go to the dentist, they put the little shields on you and things like that. So we only treat patients who have serious health conditions like cancer, where you have cancer today. Now, there's less than 1% risk of developing a secondary cancer from radiation over the lifetime of that patient.
Yeah.
So that risk is very small. But patients
For the
will ask me,
benefit,
for the benefit of potentially curing that cancer
Exactly.
at that time.
Exactly.
So patients will ask me, well, shouldn't I be wearing a lead shield during my radiation? Shouldn't I wear an apron or something while we're getting radiation in the prostate?
Yeah.
Well, the issue with that is our linear accelerator, the energy of the radiation is in millions of volts. And so it would take about 6 inches of lead to be the equivalent of what the dental hygienist puts on you, that little thing of lead. You know how heavy that is,
Yeah.
how that can feel. So we shield our radiation in the head of the machine. So as the beam is coming out, it's highly shielded and highly conformal. Yeah. And so the scatter radiation from a machine is minimal and negligible.
Yeah.
So people will ask about that as well.
So if we go back to this linear accelerator machine, at the X-ray target way up on top, there's a little I guess collimator, we call it, right?
That's
so
right.
they can
the
narrow
jaws
the beam
of the machine which comes in, because radiation, when that electron beam hits your target, it creates radiation in all dimensions like a sphere. And so you have to be able to kind of take that and shape it and direct it in one direction. And so you have all of these shielding and collimation that takes place inside the machine to give a narrow beam of radiation for the patient treatment and reduce that exposure to the rest of the body.
And that's where this treatment planning comes into play.
That's right.
Before you deliver the radiation, you will...
So before we do any radiation treatment, we run through what we call a simulation, where we bring the patient in. It's a separate appointment. They lay down on the x-ray table for the first time. We utilize some form of immobilization device, usually a mold. We'll make a mold that they lay in for treatments. We put marks on the skin, reference marks for alignment.
Little tattoos.
Yeah, that's right. And we take a scan to do our calculations, a CT scan. So that gets uploaded into a treatment planning computer where we have software that we utilize to help us direct and target the radiation, to do all the calculations necessary for that specific patient. So the treatment plan is customized to each individual patient.
So the mold is customized.
The mold is customized. The treatment plan is customized. Once, even before they come in for their first treatment, once the plan has been approved by me, then our physicist runs the plan on the machine under a radiation measuring device to make sure that the computer and the machine match and that everything that we're doing is perfect, right? So that each treatment's identical. There are tons of quality assurance measures that take place every day to make sure that each treatment is identical and safe and that the patients are being treated properly. So there's a lot that goes into it.
Sounds like it's a very comprehensive treatment planning, evaluation, and delivery of that radiation for every single patient.
Every patient. So every patient, you begin with a consultation. You review their pathology, all of their x-rays. You review their history. You go through all their medications. You discuss the treatment options, and help them make an informed choice about the best treatment for them. And then once the treatment begins, I meet with all my patients once a week as they go through their radiation to check in on them and see how they're doing, whether they're having a problem or not, and make recommendations if they're having symptoms or side effects in terms of medications to help control urinary symptoms or bowel symptoms and things from radiation until the very end of treatment. And then we set follow-up schedules after that, and we see folks back periodically. For prostate cancer, we do PSA checks every 3 to 6 months to monitor their progress and to see how they're doing, and hopefully see that they're cancer free and remain so. So it's a long process.
Sounds very comprehensive, and I will just share with you what a lot of our mutual patients have said when they have seen you and they have seen me. They have been very impressed with not just you and your services, but also your team.
Yeah.
You guys have a great team over there.
We really do.
My patients love it.
It's a really interesting thing when you come every day for 8 weeks, 5 days a week. That's 40 trips. You really get to know the technicians and the therapists and the front office folks. When you get called by name when you walk in the door, and you really feel comfortable and confident in the care that you receive, it really does say a lot for the really great office staff and the great therapists and people that work for us. We're very fortunate to have really highly skilled technicians, but also just good people, that care about what they do, care about the patients, and interact really well with them.
That's what matters at the end of the day, right?
That's all. Keeping good people around.
Yeah.
Yeah, absolutely right.
Well, before we sign off, are there any new advances in the field of radiotherapy that you want to kind of let us know? Or
Well, I think on the forefront of prostate cancer treatment is probably SBRT, or what's known as stereotactic radiation therapy. There have been some recent published studies that show stereotactic treatment to be equivalent, or showing some equivalence. We're waiting for some large randomized trials to be published on this. Stereotactic radiation is very similar to IMRT or IGRT, but it's just a little bit more targeted, a little bit more conformal, and a higher dose of radiation per treatment, where treatments could be done in as few as 5 radiation treatments. Actually, as few as 3, but 3 to 5 radiation treatments. You get your treatment done in 2 weeks instead of 8 weeks. As we said before, though, there's potential trade-offs to that, which is a slightly higher urinary toxicity that peaks higher but lasts much shorter. But control rates are looking to be equivalent. So I think in the future, maybe in the next 3 to 5 years, we may be not doing any 8-week regimens anymore, and we may be all doing these hypofractionated or stereotactic treatment regimens, getting folks done so much faster, much more convenient, while still having pretty high cure rates, especially for low risk disease.
Yeah, get people back on their feet and back to their enjoying their quality of life.
Exactly.
All right. Well, I think that we should conclude. It's been about half an hour. I try not to run these too long. If you all have any questions, please feel free to leave them in the comments. If you're watching this on the replay, hello, Elise and Sandra. Thank you for joining us. Sandra, thank you so much. 2 great men was her comment. So
that's kind.
I look forward to seeing everybody at the next Facebook Live show. It will be this coming Wednesday, and we hope to entertain you and inform you of great things in healthcare and related fields. I want to thank Dr. Davis Romney for coming on the show today. You all have a great weekend.
Thank you, Dr. Lin, very much.
Okay,
Guys,
thank
have
you.
a great night.
Good night.